Okay, we've been sent a case to evaluate a couple of different implant placements. As it looks like from here, you can see this patient has had a lot of dentistry done, and we're all very appreciative of patients that have a lot of dentistry done. So my first question when I look at this particular case, what is our initial assessment in terms of surgical guides? Based on the general rule, it is when we have circumferential restorations, we need natural teeth to be able to align the data to. And that's the rule I've always followed. But in looking at this case, we can see that our initial reaction should be that this is a upper and lower classic guide case, if we're intending to do upper and lower. Um, but we can see that in this case, they were able to very accurately have this data stitched on each other. And we'll take a closer look. Here's the upper data. And as we go through, we can see that this has actually stitched extremely well. Now, my guess would be that these are ceramic restorations that don't produce as much scatter as, say, a solid zirconia or a metal-based restoration. So we can see how nicely this has worked. So the lesson in this one is that sometimes integration will work, but what if integration had not worked? Then we would need to have the patient back and rescan them with the bite plates. But here we can see that integration worked quite well, even though we have circumferential restorations. So what was sent to us was to evaluate the implant placement. So I'll go ahead and put the implants in here. And let's go ahead and start here on tooth number, we'll call it 21, 20, whatever it is. And let's go to our implant align view. So what I'd like to do is go ahead and bring the restorations in on the CAD/CAM tab using the eyeballs here. Let's go ahead and remove the tooth data. I just want to see the restorations. So now my initial reaction to this is that we want to do in a premolar site, we typically want to start with a 4x13. So obviously, in this particular case, that is definitely not going to work. So I can see why we went to a 4x8.5. Now that's a relatively small implant. I would like to see if we can go to a 4x10. We may not. And in looking at our outline here, we can see that our bone is right in through here. The major issue that I see with this particular plan, I don't want to use the word issue as if it's bad. It's what I don't like is how much of the cortical plate we're engaging. It becomes very difficult, number one, to engage into that. It's a non-vascular bone, so we're not going to have really good integration around that. The other thing that I look at is also we're coming out the lingual cusp right here. So I would move this implant to right here. Now, what does this do? What does this bring into play? Well, the first thing that we'll all notice that this brings into play is the nerve. The second thing is grafting. And unfortunately, I am not personally comfortable dropping the going like that to avoid the grafting or dropping the implant this low to avoid the grafting. My preference is to go ahead and look at grafting this area. Now, can we go with this longer implant? And so if we went with the 10, we can see that we are getting dangerously close to that nerve. And do remember that our drill path is actually 1 millimeter longer than the implant. So I would agree that we do need to go to the 8.5 millimeter implant here. Now, the next question is how do we graft this area? And do we have to graft it? And we do. An alternative in this particular case would to maybe consider the Astra Profile implant. And here we can see that maybe with this particular implant, we could do something along these lines right there and possibly avoid the need for a graft. Now this implant does have a little more, um, it involves a little bit more work with this implant. There is definitely some learning curve with it, and you need to know what you're doing. But it is an option to avoid the graft. But let's go back to what we had in here, which was the Nobel Active implant. And so I would suggest that we look at grafting this area. Other than that, I think our plan is very well done. So I would move the implant and do the graft. The next implant, tooth number 29. The good news is this looks like this was a relatively recent extraction socket. Um, so let's take a closer look at this one. So we have enough distance between the roots. We look like we're at a decent bone level here. My bigger issue again with this is we seem to have a lot more space here on the buccal than we do on the lingual. So I would have a tendency to do something along these lines here, and then I would tilt the tooth back in to the lingual just like so. Now this has a better chance of a more proper integration, osseointegration. So hopefully that makes sense. So other than that, that's the only thing I would look at here. And then, again, depending on our comfort level with the implant, and as we go into our slider view here, we can see that right there, our implant becomes pretty close. I would even consider going to a 4.3 by 10 millimeter implant here. Again, it does look like there's an extraction socket right here. So at this stage of the game, we can't really know what kind of bone we're going to have right here, buccal plate, buccal wall. So we may need to be prepared to graft that area. Now the more complicated implant comes in the upper left-hand side, tooth number 13 or 12B or whatever we want to call it. There are some philosophical concerns with this particular implant. First, we're coming out of the buccal cusp, so in an ideal world, I would probably tilt this like so. We will need to graft this site, as we should expect with a tooth that's been lost for a very long time. The good news is this is a relatively straightforward grafting site. The other concern with this particular site is we will not get the sleeve in here. To get a sleeve in there, we'd have to go to a 3.5 millimeter implant, and even then, it's still very tight. My question becomes twofold on this particular implant. One is restorability. How thin is this going to be? By the time we get our abutment in there, ceramic restoration, are we really going to have the space to be able to seat this? Or are we going to have to really do some plasty on the distal of number 11 and on the mesial of 14 there. So that's one concern. And honestly, my bigger concern is this vertical bone defect that we see on the distal of the canine. I'm concerned about it. Um, that typically means that there's some type of active periodontal issue going on here. I don't know the attachment situation or the perioprobe readings in this situation. But I would encourage us prior to placing an implant here to try to regain bone height here through laser treatment or through osseous surgery or through whatever different means that one has available to them to be able to do this. And then come back and look at the implant here. So I'm not personally comfortable with the implant planning of tooth number 12. I'm not comfortable putting an implant there, given the vertical bone loss there and given the limited restorative space. Thank you very much, and look forward to future cases.